Very good morning, friends and doctors. Today with us is a person who has international and national credibility and experience in psychiatry. None other but Dr. Ajay Nihalani. Dr. Ajay Nihalani is a senior psychiatrist and has more than 20 years of experience. He is the member of UK Royal College of Psychiatry, American Psychiatric Association, and Indian Psychiatry Society. He did his MBBS from LLRM, Medical College Meerut, and MD in Psychiatry from SNMC Agra in May 2004. After that, he qualified for the exam for US and UK and moved to the UK in year 2004, where he joined prestigious St. Mary's Psychiatry Scheme in London. He qualified for the membership of the Royal College of Psychiatry in 2007 and was subsequently awarded for the membership. He was a student of MSc Challenging Behavior in Cardiff University. Welcome, Dr. Ajay Nihalani. Kindly make us wiser on the topic. And as everybody knows that today's topic is elderly people and melatonin.
Right. Thank you, Deepak. पहले तो मुझे चने के झाड़ पे चढ़ा दिया, चढ़ने की आदत है, कोई बात नहीं. Yeah. Let's continue with the topic then.
Doctor, what is your what is your initial comments on the sleep, which is getting impacted in today's time, especially in elderly?
Let me first generalize the fact that sleeping patterns over the ages change. Infant or a baby tends to sleep most of the time, eats, and then again goes back to sleep. And once you reach old age, there is a definite change in the sleep pattern. The total number of hours decrease. People suffer from initial insomnia. They have frequent awakenings. They have early morning awakenings. Usually people say, "Hum ullu ban gaye hain." That all happens, and that is part and parcel of what tends to happen with old age, where old age not only affects the brain, the mind, as well as the body, it affects. But at times, and what you said was in today's time, in today's COVID times, where people have greatly restricted lifestyles and they are confined to their homes, this problem has increased dramatically and drastically.
Doctor, is it obvious that you need to ignore the sleeping problem if the person is above 60 and he is not able to sleep? At what time he should consult his family physician or a psychiatrist?
Who says so? Sleep, we all know, is what gives rest to the brain, the mind, as well as the body. And if you're not able to sleep, we all know what the complications are: irritability, anger, depression, anxiety, physical ailments increasing, uncontrolled blood pressure, diabetes, etc. sets in. So for a person to have a good night's rest is extremely essential. And why should the elderly not get the benefit of whatever is available?
Doctor, in that in that COVID situation where even the doctors are giving telepsychiatry, telemedicines, in that situation, what are your line of treatments for, especially for elderly patients?
Whatever has been available, and we are using all that's available in our armamentarium to the best of our understanding and knowledge. If you talk about what new has propped up onto the shelves, I would say it is melatonin. Melatonin in relatively high doses. Earlier, melatonin was marketed as 3 milligram tablets and probably did not turn up to the expectations that we had from it, and it probably went out of fashion. If I remember correctly, Ranbaxy had also introduced a melatonin 1 receptor agonist, Rameltion, by the trade name of Ramitex. In my own practice, I think it was doing well, but somehow due to one reason or the other, it did not survive in the market, and I suppose it's disappeared now. Melatonin high doses, say 10 milligrams and onwards, is working well.
Recently, last year, according to the telemedicine practice guidelines in India 2020, why most of the benzodiazepines and drugs and Z drugs are prohibited?
I'm not exactly sure whether they are prohibited, but I would be pretty much sure that there would be restrictions and red flags added to the prescription of these medicines, because we all know that these medicines can end up being addictive. People can get dependent upon them. So right and left prescription of these the authorities would never want, and I suppose that is the reason that would be the case. We psychiatrists tend to use them quite a lot, as compared to, as I would say.
Does chances of these getting addiction or misuse increases in telepsychiatry or telemedicine?
I wouldn't say from my own practice. I have been, since the first wave, I have been doing only online consultations, and I don't think that is the case.
From the physician's perspective, family physicians.
We have a lot of fears associated with benzodiazepines. A few weeks of benzodiazepines in adequate and appropriate doses in individuals who are not prone to addiction, in my experience, does not lead commonly to addiction or dependence.
It has to be used. It has to be used wisely.
Wisely, yeah. They should be used judiciously.
Okay, Doctor, though our audience, since most of our audience are doctors, and they know about melatonin, would you put some light on melatonin in your own words?
See, we all know what the mechanism of action of melatonin is. It's mainly secreted from the pineal glands. It is the signal to the brain to switch off, which turns on when one goes into darkness, that is nighttime. Once the levels peak, that is the signal for the brain to the RAS, reticular acticulus, and all those systems to switch off and go to sleep and rest. It has been there in the market earlier also. In children, pediatricians use it quite frequently. It's also being in use for, say, jet lag syndrome, where one goes from one latitude to another latitude, travels over continents, and the time changes. But somehow, at 3 milligrams, it wasn't doing what was probably intended out of it. 10 milligram doses are well recognized, well studied, and are safe.
So how long the high dose melatonin can be given? Is it tolerable?
See, we don't have exact calculations at the moment, much insight, but what we know is in that oncology, in terminal care, it's being used up to 50 milligrams or so, because the indication there is different. It mutes the immune response that the individual has, which not only helps in the primary cancer treatment, but probably it also helps the sleep patterns and the overall care of the patient. That has gradually translated into practice, and it has come to psychiatry, and I'm pretty much sure that it will go into other branches also. 10 milligram doses of melatonin are well studied. In our practice, in fact, we have been using even higher doses quite frequently.
Doctor, it's being said that post-COVID, melatonin is a secret weapon. Is it because of plethora of benefits the melatonin is providing to the physicians post-COVID?
See, what I know about melatonin and what entails in COVID is that melatonin, as such, reduces the inflammatory response. It decreases the inflammatory markers, interleukin 1, interleukin 6, and the cytokine storm, and so on and so forth. I'm not an expert on that. But what I feel is that definitely, yes, use is increasing and it is encouraging. It should be in limited doses.
So does melatonin decreases the oxygen level like other hypnotics does?
Uh, Not that I know about, and none of my patients or from the colleagues that are using it, this becomes a problem. What you probably meant to say was, does it cause respiratory depression?
Yes, yes.
As is the case, say, with benzodiazepines, especially when benzodiazepines are used intravenously. I would like to clear here that usually in oral doses and in normal doses, even benzodiazepines don't cause a clinical problem. As far as respiratory distress is concerned, in normal individuals who are prone due to other reasons, who have severe COPD, asthma, or due to other conditions, it might be a different matter. But melatonin as such does not cause problems.
Dr. What is your final comments in the days where there are COVID-19, where there are telemedicines, and elderly sleep problem? Elderly is also majorly impacted in COVID-19. So, what is your final comments to your colleagues on melatonin and all these situations?
Being psychiatrists as well as physicians, we are all aware that we should, before prescribing a medicine for a symptomatic issue, we should always try to figure out and fix the root cause. We are all aware in the elderly, they have major comorbidities, COPD, asthma, heart failure, prostate problems, incontinence, Parkinson's, depression, anxiety, obstructive sleep apnea, restless leg syndromes. And the medicines that we use to treat these conditions, they themselves end up causing problems on the insomnia front. A lot of hypertensives, asthma drugs, beta agonists, Parkinson's medicines tend to interfere in sleep. We should be very careful about those before jumping in to prescribe a medication. Once those things have been sorted out, the individual should be advised regarding tobacco, cigarettes, alcohol intake. Sleep hygiene is very important, which we tend to forget. What is sleep hygiene? Sleep hygiene is nothing but developing a routine to go to sleep. What that entails basically is having regular sleep wake hours, avoiding late night TV, radio, heavy intake of food, fluids, uh, developing a routine. Say, for example, having a warm bath before going to bed, going for tail malish, having some milk has casein, which promotes sleep. Uh, if possible and feasible, banana kela, because it has got high amounts of calcium and potassium, which promotes sleep. We should first and foremost control the primary illness and then look to add something to help the person go to sleep, which is relatively safe and which I think melatonin is.
Thanks for making us wiser on the topic. Since elderly people are very dear to us, and in the situation where they are living with lot of comorbidities, the COVID restrictions, and also not able to approach to their physicians face to face. In that situation, as you say, that sleep hygiene and melatonin should be tried before going to the benzodiazepines or with benzodiazepines.
The other thing I forgot to mention was, say, if you look at hypnotics, say, for example, benzodiazepines or the Z hypnotics, zolpidem, zopiclone, S-zopiclone that's available in the market. Especially with benzodiazepines, a very common complication in the elderly is that once they have their dose, then because of the fact that they have prostate problems or because of the fact they have diabetes or one reason or the other, they need to wake up in the night, go to the loo bathroom, use the loo. and they end up having falls, and the complications tend to be, say, fracture femur and so on and so forth. Melatonin, because the mechanism of action of melatonin is very different, you end up having high levels, they go down, and that induces sleep. It's a safer alternative.
So you mean to say the falls, which is majorly the biggest reason that our elderlies are dying, at specifically in night. So if the benzodiazepines can increase that, and
that is a complication of using benzodiazepines.
okay.
And what tends to happen with benzodiazepines is that people, we are all aware, get hooked to it, get adapted to it, get addicted to it, and then the amount needed goes on increasing, which in my experience so far with melatonin is not the case.
Okay. Thank you very much, sir. Thanks for finding your time and energy and putting making us more wiser on this topic. Thank you. Thank you very much, sir.
Thank you, sir. Thanks for having me. Bye. Have a nice day.
Bye bye.